about it. They're 80% employed now. You know, you gotta teach them how to deal with being an employed doctor and being manipulated at every juncture. You're a tool. It's important to talk about.
And I think that oftentimes you will hear from your administration, oh, if you want to do that, you can go on and get an MBA, or you can get a joint JD.
Right.
But I do think, you know, must be ways at least to make sure that you understand what your resources are and that you know who you can talk to for certain levels of expertise, but also recognizing, you know, it's your license is your power. I mean, as we've heard, all of the constructs in terms of the legal field, like it's you are accountable. It's your licensure, you're accountable. And you know, you said there will be many opportunities where business interests will be attempted to be manipulated, but you still have immense power because you still are the one delivering. They need you.
Yeah, they do. You're the ultimate instrument of care too. And I mean, that's, you know, there's no health system without doctors. I mean, let's face it. But because they know you control so much of the money, that's where the pressure comes from. And it's always going to be that way now, fortunately. So you have to know how to play that part of the game too, you know. These medical students got an earful this weekend, and good for them. You know, they had the sense and the opportunity and encouragement to come to a conference like that. I applaud medical school for doing that. I really do, because that takes some courage on the medical school's leadership too, to say these kids need to hear this. They do, and we did it, and you did it. You know, I'm proud to be here. This is law school and med school all at once. I never seen this before. The best I could do, bringing the two disciplines together, was the LA County Bar and the LA County Medical Association put on a combined program every year. Professor Melvin came and addressed us one year. We do one program every year. We pull no punches. And we talk about things that, like Alicia Macklin talked about, recovery actions. Room fills up because LA County Med with their 7,000 or 8,000 members got maybe 200 or 300 of them that are undergoing a recovery action right then and there. So they come to hear the best of them talk about it. Well, you did a little bit of that in this. So the med school administration, my hat's off to them for promoting it and doing it. Taking the blowback from administration above you that's going to tell you you shouldn't have been doing that. That's, you know, you always think, well, administration can do whatever they want. No, they can't. They got bosses too. So it takes a certain amount of courage for the medical administration. I'm proud of you.
Yeah.
Oh. Okay, the groups are returning, so if you want to wrap it up and let we'll see what it came up with.
We got a plan.
I'm never bringing it.
You do yours.
No, you can't.
No,
I don't have the notes.
I'm gonna share.
Talk about education and residency. What about
I right now, starting with the Medicaid.
right?
This is trying to really
No.
So when I go back.
That's pretty good.
Why was that? Why would that help?
They're just grabbing confusing.
It slowly went down.
I don't think that's from the paper, that would be, you feel like on.
I promise you this is.
I will take it. Only if that means you're.
I'll read it.
That was just because I was on the wrong document. Yes, I saw it come out. But they did get blended together. So we got on the Zoom later. So yeah, well, it was two people. There was four people. No, I'm sorry, there were 6 people. Two of it's an answer solutions. They probably were, you know.
Oh, I can just like.
You. And then the meds.
Disgusting.
Anybody not here, please raise your hands.
They were good, they were good.
Yeah, sorry.
All right, well, let's reconvene. Let's hear first from our remote attendees and the facilitators for that group. What did you come up with? What are we doing to fix this? And I'm gonna write the ideas here and we'll just keep a record.
So one of the things that we talked about several things,
Oh,
but
wait,
one of them.
need a mic.
Can I just enunciate? Oh, okay, fair.
And it won't be recorded for posterity. Back, don't want you.
Yippee. Thank you.
Okay, can everybody hear me? Okay, so one of the things that we talked about was in the peer-to-peer review process, holding the other physician accountable for the outcome of whatever the result is. So usually it's just the prescribing physician that's held accountable and not the other peer. So we talked a little bit about like what that would look like, and someone said that they do know a physician that does a little bit more indirectly holding them accountable, such as like asking for the doctor's name, their specialty, the state they're licensed in, and recording all that in the patient's chart. So it almost makes that peer feel like they're accountable, but kind of formalizing that process and making it something that all physicians do.
Hey, hold on, let me make a note.
Mr. Millman. When we're talking peer-to-peer, is this in the arena of prior authorization?
This is prior authorization, right?
Yes.
Okay, by the way, can I be heard or do I need a microphone?
Yeah.
No, I mean in terms of the recording. Okay, if I need to be able to be here, I need a microphone. Do we have another microphone? I need one.
And then another thing we talked about in the realm of the appeals process was something we talked about in class a little bit, but basically having a process for appeals that allows physicians to kind of make time for that process, because right now it's kind of rushed and they kind of just have to get through it because you have to be seeing patients and you can't spend a ton of time on appeals processes. So giving them more of an opportunity to do that, because the physician we talked to said, like, if you keep going to the next person and allowing them the time to do that, then eventually the physician's gonna get what they want.
Did you talk about how to get into the weeds of how to give physicians more time to do that? Did you get into that?
No, this is what we were talking about, like right before we ran out of time, so.
Okay, good.
Those were two of the main things that we dived into. We talked a little bit about like the corporatization of practice, and we emphasized like state regulations like we talked about earlier in the forum, but such as like the retaliation statutes and things like that. But
Did you have any specific recommendations with regard to retaliation statutes?
no, there weren't any specific ones.
Okay, all right. Anything else from the remote group? If not, let's go to one of the groups, whoever would like to represent one of the groups, report on what they said. We'll get to this group last. So there were two groups in the conference rooms. Who would like to tell us what you came up with?
I can try to organize our notes.
Don't worry about organizing.
So the first thing we talked about was, well, one, the idea we need to remove pre-authorization decisions from insurance companies. I think we came up with various different ideas, all surrounding the fact that physicians or specialists should be the ones making these pre-authorization decisions or set of standards that exist surrounding pre-authorization. It was discussed maybe those things would go through the American Medical Association or state level medical associations. And then I guess there could be state or federal law passed to help include physicians in these decision making for how these standards are created.
Okay.
We then went to where to define medical necessity. We had lots of different ideas surrounding this. Obviously, the sure solution to it would be federal law defining what medical necessity is. But we found that that would be probably the most difficult decision, and given how quickly the political climate is changing from one side to the other, you could have a definition of medical necessity that happens one year and then is completely repealed and redefined the next year. So that jumped to possibly state law defining medical necessity. But ultimately, that decision of how medical necessity would be defined needed to be in the hands of physicians. So the group came up with, I think, what was the acronym for that organization? You?
Grant, the task force?
Yes.
Yes, so expand United States.
This is,
Oh,
Yeah.
United States for
Yeah,
Yeah.
USPSTF.
So on the federal level,
yeah,
expanding the reach and I guess decision-making power of the US
PS.
yes, preventative task force, we'll call it that. And then the law students in the group went back to, given the Chevron decision has been taken down, there could be issues surrounding the power that these types of executive agencies could make these large decisions about what medical necessity, given it would be $1 trillion decisions possibly. So that led us to possibly have these same type of task forces at the state level and defining medical necessity at the state level. Let's see. And given so that the state level task force might get less pushback legally for what the amount of power that they can have. Medicaid for All was discussed as a way to prevent all of these things from being an issue. And then the last thing we talked about, it goes, I guess, the root of the issue of why there's so much polarization around what medical necessity is where the money is going in the current healthcare system. So preventing for-profit insurance, and then we talked about IP rights for drug manufacturers and keeping a lot more IP rights with the government and state institutions, other various ways to prevent getting power in the hands of people who are just looking for profit rather than better care for patients.
okay. Okay, very good. Anything else from that breakout session that,
Oh, another thing to talk about, one more. We talked about unions as well, and the two things that were discussed, that unions are a good thing with certain parameters. Physician run unions was something that was very important to our group. We didn't want unions that weren't particularly focused on physicians themselves and the various contractual provisions that they desire versus collecting union dues, or that there's a balancing of priorities between different types of workers within that union. So if you're going to have a physician union, it needs to be just for physicians, run by physicians. We also discussed residents unions and how beneficial that might be for how residents are treated, the hours they work, and preventing the current shrinkage of residency positions that exist. And then we talked possibly about medical student unions to preemptively prevent all of these issues, but we didn't know how possible that was.
What would they be striking for?
Well,
Fewer classes?
no,
No
I guess
exams?
I posed the idea that medical students could come together and because they are the ones that are signing a lot of these residency contracts, agreeing amongst each other to not sign residency contracts that contain certain provisions or not contain certain provisions, but that could create for even more tumultuous residency process.
Well, we'll come back to that when we talk about what can medical students do in the next breakout sessions. All right, anything else from that group? If not, let's go to the second group that was out in the seminar rooms. Who can speak to us about what that group came up with? Right behind you.
A couple things. Sorry. So we discussed, we kind of discussed a different aspect of physician contracts, specifically in Ohio, and we talked about possibly prohibiting some of the provisions in contracts that would lead for doctors to be retaliated against. And those specific ones would be termination without cause, non-compete, gag clauses, and arbitration provisions potentially.
Okay.
And then we also talked about like the efficiency aspect and to get physicians more time with the patients. And this less time with patients is kind of driven by the demand for efficiency in medicine. So one of the things we maybe talked about was increasing like PA's role in healthcare and in serving patients to possibly give MDs more time with patients. And then I don't know if I'm going to be able to explain this the best, but we also talked about placing limitations on what private equity limited partners can invest in through the certain funds that they invest. And there's usually demand for higher efficiency when hospitals and other medical organizations get bought out and combined into these conglomerates, which would introduce other issues, but that was kind of the initial thought that we had.
Good. All right. Anything else from that breakout group? All right. If not, let's go to the third breakout group, fourth. Spokesperson. Yes.
So we were mainly talking about developing and enforcing every state to have a law regarding anti-retaliation. And then we were also talking about having some sort of database for anti-retaliation cases so that the information is more accessible to everyone. And then we were also talking about interdisciplinary education between lawyers and all hospital employees. So that includes, medical students, social work students, psychology students, any kind of hospital employee. And then we were also talking about
Interdisciplinary
education.
education.
Yes.
Okay.
And then the last main thing that we talked about was having medical legal programs. Dr. Badanti was specifically talking about how in LA, the legal department and the medical school combined, but not necessarily like having an MD JD kind of program, but just like maybe like specific classes or some kind of thing like that.
Good. Okay. Anything else from that final group?
Okay, just to quickly add on to the laws, Dr. Patante he specifically mentioned like that we can just like there are two California laws that we can use just as like a template. So California BMP law, if I'm saying that right, 2056, and California Health and Safety Code 1347. So just the idea that we don't have to start from scratch, you can just take some of these provisions that are already exist and just bring that to the state here.
Or everywhere, right? Others?
Other things that we also talked about is to teach residents how to negotiate contracts once graduating residency and getting their first job. The second thing is to increase residency spots. That's what we talked about, like having NPs and PAs kind of overtake those spots now, because there's lack of accessibility to healthcare. And they say that, but then they don't increase the residency spots for our residents to take those positions and health providers.
Okay. We, by the way, just FYI, when we were planning this conference, there was a suggestion that we focus not only on medical students, but residents. And we decided not to, just because in the interest of time, residents face, in addition to the issues that medical students will face when they become residents, you know, they face specific issues. So we just wanted to save that for another time. So maybe you will help us put together another program for residents.
Wonderful.
Okay. Anything else from that final breakout session? If not, yes, no? Okay. So any thoughts on these ideas?
I think the group over on, in that side, in your first issue of peer-to-peer responsibility, and what we're talking about are physicians in administrative roles who take a part in patient care. Because everywhere you see a bad decision, there was a physician hired to do it. And they have no liability at this point in time. But in California, there's one code, two codes I want you to look at. Let's look at the one that's turned against physicians, which is California Business and Profession Code 725. This is a code that says it is unprofessional conduct for a doctor to overprescribe or overtreat or overutilize tests. And that code is used constantly against practitioners who have dispensed opiates, and there's been an untoward outcome. It's used all day long, B&P 725. The corollary to that code is Business and Profession Code 733, which was enacted at a time when pharmacists and other people were denying the prescription that a legally prescribed opiate was given to a patient. Pharmacists said, no, we're not giving it to you because we think this is a bad patient or a bad doctor or both. So Business and Profession Code 733 was enacted that said it is unprofessional conduct to deny it was a medical device, and drugs, I think, were the only two parts that rendered the deciding, that the denying person, any licensed person, that care. So Grace and I this year expanded that 733 to make it unprofessional conduct to deny legally prescribed and medically necessary care, drugs, treatment, studies, or anything else. We're trying to get to the same problem you were talking about. We want to make it unprofessional conduct for those doctors to do what they're doing. Why that statute? In California, if you are found unprofessional conduct, you must be disciplined. Must be. So that's why we're utilizing that code. So in your further debates and in your ongoing discussions and trying to implement maybe Ohio law, look at California Business and Profession Code 733 to put the monkey on the back where it belongs.
I just ask a really
I'm wondering if I can just ask a question about that, just because I think that's such a wonderful point that was raised by this group. And there are many of us out there who are required to do these peer-to-peer assessments. And we do ask for the name and the state and the licensure of the physician who is doing this peer-to-peer with us. And more recently, those have been told they don't have to disclose that information to us. I think probably because they've been advised that that may be something that would end up in the court. So there's then no requirement that they need to document who they are. Is that, I'm just wondering what the structures are in place.
In California, the legislature has been on the avant-garde of these issues. And I think it's Health and Safety Code 1367 in California that talks about having a qualified similar specialty deciding peer-to-peer questions. The problem is no enforcement. That's the problem. We got laws up the wazoo, no enforcement. So a law without enforcement is basically useless. So I think that going forward, enforcement is going to have to be incorporated into any of these ideas. And an enforcement with penalties so that it really, it takes a bite out of you if you violate the law. And until that happens, it's going to be easy for payers to hire doctors. They got no liability.
Follow up on that. I mean, one of the concerns, if we make it very sort of fraught for the doctors who advise insurers about whether to approve something or not, if we make it, if we create liability for them and we make their names public and so on, who's going to want to do that? I mean, you said, well, they're paid to do that. I mean, can we be confident that there will be enough, competent physicians who will be willing to, be on the other side of the treating physician? If we make it really, really onerous and potentially dangerous for them?
I'd like to respond to that, because that's a I want to respond to that because that's a comment that you always hear. Well, you're going to stifle legitimate cost containment because you're not going to have doctors that want to do it. I disagree 100% with that. First of all, if you're doing the right thing, you would have no problem doing it. If it's medically necessary, you grant permission. If it's not, you don't. So it's a fundamental question. Is it medically necessary? That's the first question. Second is, can you hire people to do that? Well, if you're not asking them to violate the law and you're actually asking them to do the right thing, there should be no problem because there's plenty of retired doctors that can do an administrative job without the rigor and the demands of patient care. Payers say, oh, you're going to drive costs through the roof. My comment to that is, if you really knew how much medically necessary care is out there and identified it and admitted to it, you could contract for it and know exactly how much you're going to spend instead of wholesale denials and then try to sort through all that through litigation. It's a big mess. Why not do the right thing from the beginning, see how much demand there is, contract it out, and keep your costs like that. That's when you're doing real medicine.
Other thoughts, other comments on the suggestions? There's one over here. And let us know, Lucas, if anyone off the remote.
Just wanted to add, the thing about finding competent physicians to be like medical officers for reviewing claims at insurance companies. Can't name any names, but some of them aren't especially competent. The ones that are denying thousands of claims a day. ProPublica has done investigations and found that, they lost a medical license in another state and they basically fled the state and ran to another state, work for the insurance company and denying claims. And they should not be there. Let's just say that. They're not competent for that role either.
So that was ProPublica that has done a study? Okay, that's interesting.
I know in Ohio, many of our Medicaid managed care organizations had required their medical directors to have some level of concurrent clinical care. However, I don't know if that has continued, because I now know of medical directors who do not have any form of continuation of their clinical care. Can you talk a little bit about how those organizations are regulated? I mean, they also have to deal with a significant amount of regulation, at least Medicare and Medicaid, and then also talk a little bit about how those private insurance are, like in terms of the leverages around this type of enforcement and regulation.
Other comments or thoughts? I have a couple I just want to mention. One thing that came up yesterday, and it's kind of suggested by peer-to-peer accountability, that idea of holding insurers to, holding them to account when they make decisions that are improper, deny medically necessary care. There have been attempts over the years to sue insurers for denying medically necessary care, and they basically are malpractice cases aimed at insurers, and they are largely been unsuccessful because what do the courts say? Insurers don't practice medicine, doctors practice medicine. So doctors are calling the shots, not the insurance companies, and we cannot hold them to the standards that we hold doctors to, which is a sort of conundrum. I'm interested, the idea of, let's get some federal or state determinations, interpretations or rules for medical necessity, what is medically necessary or not. I mean, so think about it. I mean, one of the things that we have struggled with in this country, that other countries have sort of resolved, the ones that have national health systems, is who decides what we're going to pay for. And, the idea that we should delegate that to the government as opposed to the private sector in whatever, flimsy, faulty ways it does it, is a very, interesting but very sort of controversial idea. Go back to Sarah Palin's death panels idea. And as the students in my healthcare controversies class knows, to some extent we do that for Medicare. For example, we have national coverage decisions that Medicare makes. We also have local coverage decisions that Medicare contractors make about whether something should be covered or not. But again, there's a real problem with accountability and reviewability of these things. So think about, do we want, at what level and by whom do we want these medical necessity judgment calls to be made? For example, do we want them to be made by Hearst Communications, by Interqual and so forth? Or do we, how do we do this well? Okay, so this was very good. A lot of interesting ideas. What I'd like to do is take maybe a short break. I think there's some refreshments out there now, or if not, they should.